So I might hand over to Kent. Kent, how are you going?
Great, thanks Josh. Thanks for hosting a session today, and really look forward to hearing what Doug has to say. I guess a little bit about our presenter initially. Doug Richie received his DPM from the California College of Podiatric Medicine. He completed a postgrad surgical residency program at Western Medical Center, and he's certified by the American Board of Foot and Ankle Surgery and is a fellow of the American College of Foot and Ankle Surgeons. He's also a fellow and past president of the American Academy of Podiatric Sports Medicine. His research interests have included studying prevention and treatment of the ankle sprain, as well as pathomechanics of flat foot deformity, which is really well known for. Dr. Richie is a two-time recipient of the American Podiatric Medical Association Research Award and has also received the Richard Schuster Biomechanics Award from the American Podiatric Medical Association. He holds 5 US patents on technologies regarding manufacture of footwear, ankle brace design, and foot orthotic design. He recently retired from 38 years of clinical practice in Seal Beach in California, with faculty appointments at the California School of Podiatric Medicine and at Western University School of Podiatric Medicine. Dr. Richie devotes his time now to teaching, original research, and writing. His recently completed book, The Pathomechanics of Common Foot Disorders, is a must-have for anyone treating foot and ankle conditions, from students through to experienced clinicians and educators, and is available to purchase both in ebook and hard copy form. Simply, Doug is a legend in our field. I feel lucky to know him personally and to be able to work with him professionally. I think we're all fortunate to be able to continue to listen to and learn from Doug. So over to you now, Doug.
Well, thank you, Kent, for that nice introduction and those very kind words. And I hope you enjoy your lunch while we share some interesting insights into how we can offload structures that are commonly injured in the human foot using a new technology which I developed called the Richie AeroSpring Bracing System. I'm so pleased and honored to be working with Kent Sweeting and Queensland Orthotic Lab. They are the exclusive manufacturer and distributor of the Richie Brace family of AFO products in Australia, and they are partnering with me to provide this new technology, which we're going to learn about shortly. The lecture outline, basically we're going to talk about how we currently offload injured structures in the clinical setting. We're going to review what we know about the biomechanics of carbon fiber ankle foot orthoses. We're going to start with looking at trends for treatment of Achilles tendon injuries, particularly the Achilles tendon rupture. And then we're going to carry forward to other clinical applications of carbon fiber bracing for plantar fasciopathy, midfoot arthritis, and drop foot conditions. So we basically look at this and say, when we have an acute or even sometimes a nagging chronic injury of the lower extremity, the mainstay of treatment, at least in the United States, and I assume in Australia, is to immobilize. And the preferred method is the so-called walking boot. And we will use the walking boot certainly for long-term immobilization for challenging conditions such as an Achilles tendon rupture, a midfoot or Lisfranc sprain, after surgery, for example, with an arthritis of the hindfoot or ankle, and sometimes for other chronic injuries such as an osteochondral lesion of the talus. More and more practitioners will implement walking boots for recalcitrant heel pain, insertional Achilles tendinopathy, troublesome fractures like a Jones fracture, and certainly after surgical reconstruction for flat foot deformity. The problem is patients don't like these devices. They're bulky, they're uncomfortable, and they will often tell you the sooner they can get out of the device, the better. And that's why many companies offer a continuum of immobilization, from a walking boot to an ankle brace to a soft support, really appeasing to the patient to try to restore mobility and get them back to play, but oftentimes before the injury is actually healed. So I think most of us should be aware that when we implement walking boots, our patients probably aren't wearing them all of the time and may actually be wearing them only 50% of the time. This study, well known among most practitioners with patients with diabetes, with a monitoring device placed inside of a walking boot, illustrated the fact that patients were only wearing their boot 30% of the time they were on their feet. Why do people not want to wear walking boots? Well, sometimes these boots pose a greater threat to their overall health than the condition actually being treated. We know from certain studies of patients in walking boots that there are significant gait disturbances due to restriction of ankle joint motion, limb length discrepancy, and it accounts for the fact that most of these patients develop pain in the hips and knees when wearing a walking boot on a daily basis. The other critical factor is the balance inhibition. When we restrict ankle motion, we take away a key proprioceptive input for upright standing, walking, and balance. And by taking away the ankle strategy, patients have to rely on their hip strategy for balance, and they feel unsteady, uneasy, and feel a risk of falling. What happens when we immobilize the patient's right lower extremity and they have to drive an automobile to the workplace, to go shopping, visit family and friends? This is a press release from a local newspaper near my office, which is near a large boat marina in Seal Beach, California, where a patient named Larry, who had recently had foot surgery, was wearing a medical boot on his right foot and couldn't control the automobile and drove it literally into the bay. I was concerned that this was actually a patient of mine, but it turns out he wasn't. And I was relieved to find out that both Larry and his elderly mother were rescued from the automobile before suffering injury or death. As a quick add-on, the AeroSpring brace is fully releasable at the proximal strap to allow plantar flexion of the ankle so that driving an automobile can be carried out safely without any inhibition of ankle joint motion. So that's one selling point of a AeroSpring brace over a walking boot. The bottom line is using a primitive walking boot to immobilize injured structures is just that, it's primitive. And there's a lot more we can do now based on good science. We need to immobilize, at the same time allow functional rehabilitation of common musculoskeletal conditions affecting the lower extremity. I'm going to show you a quick video introducing the AeroSpring brace.
Introducing the Richie AeroSpring Bracing System, the antidote to the walking boot. Here's why. The ordinary walking boot is heavy, has significant limb length discrepancy, significant gait disturbance, cannot drive a car, significant balance comp, 0 foot support, no dynamic tendon loading, contact pressure at the ankle, and minimal reimbursement. The new Richie AeroSpring is lightweight, no leg length discrepancy, near normal gait, can drive a car, minimal balance compromise, total foot support, alignment, dynamic tendon loading, no contact with ankle, and a handsome reimbursement. And when running, something you would never even try in a walking boot, the spring effect of the strut flexing actually helps propel the runner forward while providing full support. And you would never try to drive in a walking boot.
So basically, what I've designed is a system approach using a carbon fiber AFO, a custom foot orthosis, and in some cases, a graduated heel wedge to address 4 challenging conditions that podiatric clinicians face in a daily basis. And I'm going to introduce each of these to you in the subsequent lecture. Before doing so, I want to talk about carbon fiber ankle-foot orthoses, which may be new to many of you, and show you some of the interesting insight we've gained from research using these devices for neurologically impaired patients. So before we do that, we should really evaluate the phases of the gait cycle where an AFO can come into place. And if we look at how a fixed position carbon fiber AFO, which has the ability to deform and spring back, we realize that the AFO can maintain the ankle in a dorsiflexed or neutral position, keeping tension on the calf muscle during swing phase. This is helpful in drop foot conditions. It allows a heel strike and engages the first rocker of the gait cycle. More importantly, it controls tibial progression during the second walker. This is when the tibia migrates forward over the fixed foot on the floor. The AFO has the ability to restrict ankle joint dorsiflexion during the mid-stance phase of gait, and during that time, it stores elastic energy. As a result, it assists in push-off during the third rocker as it recoils back and enables push-off. Multiple studies have been carried out on carbon fiber AFOs, particularly comparing them to traditional polypropylene. The advantage of carbon fiber is that it has a force versus deflection relationship that allows energy storage and allows the improvement of gait with energy return and push off. This is not seen with traditional copolymer plastics. A recent study by Wolf showed that the carbon fiber AFO was enabled to improve push off in neurologically impaired patients. Comparing carbon fiber AFOs to plastic AFOs, we see improvements of ankle joint plantar flexion moment, walking speed, stride length, and more importantly, decreased energy cost. This study showed comparing carbon fiber to plastic, carbon fiber returns energy at 88% compared to plastic at 77%. The spring-like action of ankle-foot orthoses and energy cost was described by Bregeman in this study published in Gait and Posture in 2010. And in this study, they showed that the spring-like effect of a carbon fiber AFO reduces muscular activity in the calf musculatures. And it gives an artificial push-off during the third rocker. This is important for several of the conditions I'm about to describe. Carbon fiber foot plates, not even AFOs, are now recognized as a significant adjunct to certain phases of the walking and running gait cycle. Many of you are aware of the new technology in these super shoes started by the Nike Vaporfly, where inside of the shoe is a carbon fiber foot plate, as well as other innovative features that have enabled this shoe to provide improved energy conservation and improved athletic performance. But for our purposes, it's interesting to see how the addition of the carbon fiber foot plate and other features affect ankle joint moment and the first metatarsophalangeal joint. And at least for the Achilles, we see decreased eccentric and concentric loading on the Achilles and negative ankle joint power during the walking and running gait cycle. This can be a positive factor in terms of protecting an injured Achilles during ambulation. So if we look at the studies on carbon fiber AFOs, we realize that they have multiple effects on different muscle groups, starting with the ankle joint dorsiflexors, where we see enhancement or replacement of dorsiflexion to enable the first rocker. In terms of the ankle joint plantar flexors, they're definitely offloaded during the second rocker or during mid-stance. And then when it comes to push-off or the ankle joint plantar flexors, there's definitely energy returned and enhancement. So we know that we can offload the Achilles and tensile strain, not only in the Achilles, but in the plantar aponeurosis, as well as compressive forces across the midfoot joints, as we decrease load during that critical second rocker of the walking gait cycle. So we're going to go over these various pathologies and talk about how an AFO combined with a custom foot orthosis can provide a new novel approach for offloading and recovery. We'll start with the Achilles. And as most of you are aware, we're seeing increased incidence of both acute rupture of the Achilles tendon as well as tendinopathy condition of the Achilles in adults around the world. And there's various reasons for this, which we'll not go into in this webinar, but we know it's true. Achilles tendon ruptures have nearly doubled in incidence over the past 10 years, as this study in Finland underscored back in 1999, or actually 2008, and that trend has continued. But the more important trend is we're learning that we don't have to surgically repair the ruptured Achilles. There's been a gradual trend around the world to treat the Achilles tendon rupture non-operatively, and we get similar results to those patients who are treated with surgical repair. Now we have many randomized clinical trials, really over the past 20 years, comparing surgical versus non-surgical intervention for the acute Achilles tendon rupture. And as this meta-analysis showed, there is an insignificant difference in the functional recovery between surgery and non-surgical approach to the acute Achilles tendon rupture. The most recent systematic review and meta-analysis was published by Rita et al. Just last year. And in that, there was no statistically significant difference in functional outcome between the two treatment approaches. Both give equivocal and satisfactory results. The only difference is re-rupture rate. There is a significant lower re-rupture rate in the surgically treated group. However, there are more complications in the surgically treated group. So one has to weigh the benefits and risks of deciding whether to do surgery. What it really boils down to, as this study showed, is the initial gap size across the rupture site of the Achilles. No matter what, whether we do surgery or treat them non-surgically, an early functional rehabilitation program gives better results than strict immobilization. But the patients who do better are patients who have a smaller gap size detected by ultrasound with the ankle in full plantar flexion. So if we can see a gap size of 5 millimeters or less, we know those patients will do well with a non-surgical conservative intervention. A prototype program often quoted now in the literature was illustrated by Hutchison et al. In 2008 called the SMART Rehabilitation Program of the Ruptured Achilles with non-surgical approach. They found that patients who did well or needed surgery were those under the age of 50, had a tendon gap greater than 1 centimeter, they had already had a previous rupture, or there was a delay in diagnosis greater than 2 weeks. These are the patients who need surgery. The patients who do well without surgery and a non-surgical approach are over the age of 50, have good tendon apposition, they're diagnosed early, and of course, if they have other comorbidities, they're not good surgical candidates. So when we come to looking at whether to treat them conservatively, what does the literature say about offloading protocols? When do we bear weight? When do we begin range of motion and strengthening? And what's baffling here is there's no agreement. This quote, while the literature is rife with publications describing modifications to the documented surgical techniques, the volume of surgical literature is still eclipsed by the number of postoperative protocol descriptions. Surgical post-op protocols do not follow any single agreed upon approach, and it is the same with non-surgical treatment. In the end, how we offload the Achilles, whether it's surgical or in the non-surgical management, seems to be identical when we look at published studies. The first question is, when do we allow patients to bear weight after a surgical procedure to repair the Achilles or a non-surgical approach? What is the protection we use? What position do we place the ankle in? when to begin range of motion, and other exercise protocols. 30 years ago, the agreed protocol across the board was rigid plaster cast immobilization, usually above the knee, with the ankle placed in a 30-degree plantar flexed equinus position. But over the years, we've learned that patients who are allowed to bear weight earlier and have the ankle moved out of equinus actually do better than patients treated with the more traditional protocol. This prospective study by Suchak et al. Showed that patients who had early weight bearing after surgery, in this case, did better than those patients who were non-weight bearing and strictly immobilized. So if we immobilize the patient after an Achilles tendon rupture, whether we do surgery or not, how do we immobilize and what position should we place their ankle in? The tradition is to place them in equinus, the theory being this brings the torn tendon ends into close apposition and allows rapid healing. However, we've learned that this is not always the optimal position for healing and recovery. This study by Rebecca Kearney in 2012, and I'll show you some other studies she's done in Great Britain, concluded that immediate weight bearing after an Achilles tendon rupture is safe. But in terms of what type of device they should wear and what degree of plantar flexion, at the time of her original study in 2012, she didn't know. She suggested further research, which she did carry out, and I will show you the results of that shortly. What we have to understand is that placing a patient in an equinus position after an Achilles tendon rupture is not always optimal for healing. We have various orthoses to position the ankle in equinus. One of the most popular and probably the best is the Vacoped boot out of Germany, which has an inner pneumatic liner for compression and has an adjustable footbed to achieve a 30-degree equinus position and gradually reduce to neutral. Other boots, such as a cam walker, calibrated ankle motion walker, actually plantar flexes the entire foot plate off the ground, and I'll show you what happens when we do that. And then finally, in the United States, the most popular treatment is a standard walking boot, but placing graduated heel wedges inside of the boot to position the ankle into equinus. We should pay attention to a recent study published in the Journal of Foot and Ankle Surgery, where they took x-rays of patients placed in this walking boot with heel wedges. And they found that depending on the type of wedge and the type of boot, that the ankle didn't always move into equinus. This x-ray taken of a patient in the boot shows a neutral ankle. In number B, we see a patient in an equinus cast, not in a walking boot, and certainly the ankle is now in equinus. In C, this is a boot where the entire foot plate has been plantar flexed, such as the Vacoped boot. Again, they're in equinus. But D is the traditional method of placing simple heel lifts under the heel only, leaving the forefoot unsupported, and indeed the talus is not plantar flexed at all. So heel lifts inside of a shoe or a walking boot have variable and unpredictable effects on Achilles tendon strain. Moving ahead to studies of heel lifts in runners and how we use heel lifts to offload the Achilles, we find that the reaction of runners is quite variable from individual to individual. Some individuals have a negative response with actual increased loading of the Achilles despite wearing a heel lift. And this brings up an important point to look at the pathomechanics of Achilles tendon loading. We have to realize that the Achilles tendon force peaks at the same time ground reaction forces peak in the forefoot during push-off. Achilles tendon force here, ground reaction force here. The maximal Achilles tendon force is during push-off. Another study showing this clear link between maximal Achilles tendon force and heel rise, push-off, also known as the terminal stance phase of the walking gait cycle. In terminal stance, the heel rises off the ground. During this time, the calf muscles are contracting concentrically. But what's interesting is they're generating push-off not by plantar flexing the ankle. They're generating push-off by flexing the knee. In terminal stance, there is no plantar flexion of the ankle. The heel rises off the ground because the knee flexes. The heel lifts off the ground due to tibial migration forward due to knee flexion. All of the action is at the knee joint. And this is important when we look at the use of heel lifts to allegedly offload the Achilles. As the knee flexes and the heel rises off the ground, the use of a heel lift would really be of negligible value in shortening the distance of the Achilles or altering ankle position. So this is something we have to recognize, is that a heel lift doesn't necessarily plantar flex the ankle, and the ankle doesn't plantar flex during the critical phase of heel rise in the walking gait cycle. The way we can offload the Achilles is to reduce muscular activity in the calf muscles and give an artificial push-off, which can be accomplished with a carbon fiber AFO. Heel lifts have interesting effects on the foot that we have to recognize. When we place a simple lift under the heel, it doesn't necessarily plantar flex the ankle at all. It's only when we place an extended wedge from the heel to the metatarsals that the entire foot plantar flexes as one unit. So we have to contour a wedge from the heel to the ball of the foot, and most accurately, this is done with a custom molded functional foot orthosis. Certainly, a higher heel shoe will plantar flex the ankle and will decrease strain in the Achilles, but we see some interesting effects when we do this. We'll talk about that later. So when we talk about placing the ankle in equinus and protecting the Achilles, we have to realize we have some negative effects in doing that. We immediately place a slack tension on the Achilles, which reduces muscle activity. This was an interesting study by Ratanen et al., published in 1993. And in this study, they showed that if they immobilize the calf muscle in some degree of tension, there's less atrophy. When we place the ankle in equinus without any tension on the calf, we have immediate atrophy of the calf muscle. Another study showing placing the ankle at 30 degrees of plantar flexion reduces calf circumference and calf muscle strength over time. Another study done on rabbits showed that placing the calf in a shortened position with the ankle in equinus developed serious atrophy within 4 weeks, which was not reversed by subsequent immobilization at a normal length. What we know is that when we shorten the Achilles, there's an immediate adaptation of the calf muscles, particularly the soleus, which cause a reduction in the number of active sarcomeres. Finally, we know from strategies of improving tendon healing that if we do not load the injured tendon during the recovery process, we have inability to form collagen type 1. And as I've already shown you, we have negative effects on the myofibrils and calf muscle atrophy. So we have shown basically that when the foot is placed on the ground with immediate weight bearing, early on after an Achilles tendon rupture, as long as it's protected, there doesn't seem to be an increased risk of re-rupture compared to those who are non-weight bearing. But we've also found that there is better restoration of calf muscle strength during the recovery process. Now, as we go from top to bottom, we're seeing practitioners position the ankle back to neutral much earlier during the recovery process, sometimes even immediately. When we put the ankle in a fully 30-degree plantar flex position, there's other changes that occur. When a patient is in a walking boot such as this, a study by Froberg, quite interesting, placed a strain gauge in the Achilles in patients walking in a 30-degree plantar flex boot And they found that actually when the boot was plantar flex, they had greater tension in the Achilles compared to when they walked in a neutral boot. There was a compensation that occurred as the calf muscle fired inappropriately in this awkward, unstable position of plantar flexion. Patients should not ambulate in a cast or boot where the entire foot plate is plantar flexed after Achilles tendon rupture. Leaving the footbed at neutral and then using a combination of heel lifts and a foot orthoses, which slightly plantar flexes the ankle, appears to be the optimal situation. What about carbon fiber AFOs? Well, I mentioned Rebecca Kearney, and she followed up with an interesting study published in the American Journal of Sports Medicine, where she looked at patients in a walking boot compared to a carbon fiber AFO. And she studied plantar pressures as well as electromyography. These were the carbon fiber AFOs, quite similar to what we use for the AeroSpring device. She found that walking boots had negative changes both with heel pressure and with temporal spatial transfer of weight during the walking gait cycle. This accounts for why patients develop pain in the hip and knees. However, she found almost a normal walking cycle when patients wore a carbon fiber AFO with a 1-inch heel raise. She concluded that this would offload or protect the Achilles while restoring a normal gait, especially compared to a walking boot. She felt that this would lead to an accelerated return to function and avoid the effects of disuse atrophy in the calf musculature. So we think the optimal system to facilitate healing of an injured Achilles tendon, particularly after rupture, would be a carbon fiber AFO inside of a standard lace-up shoe, starting out with a 1-inch heel raise, and of course using a contoured foot orthoses to assure that the entire foot is plantar flexed at the ankle to offload the Achilles. A 1-inch heel raise is basically 2 centimeters or 20 millimeters, and it should be applied bilateral in the patient. So this would be the AeroSpring brace system designed to offload a ruptured Achilles. Now, whether this is the optimal system for Achilles tendinopathy is up to the individual practitioner. Depending on the symptoms, one may want to start with only a 10 millimeter heel raise, and within several weeks, depending on symptoms, bring them back to neutral as soon as possible. The brace should be worn after Achilles tendon rupture for 8 to 12 weeks. We gradually reduce the heel raise from 20 to 10 millimeters, and finally down to neutral, usually by the 8th week. Even if conservative treatment fails for these conditions, the brace system can still be used in the postoperative management. So not only can we use this offloading system for the acute rupture of the Achilles, but we can use it for other challenging conditions of the Achilles, including insertional tendinopathy, mid-substance tendinopathy, and as we're about to talk about, plantar fasciopathy. Briefly, insertional Achilles tendinopathy is a little different animal because of the peculiar relationship and the association with the triad, the Haglunds, the bursitis, and the insertional spur. A lot of speculation about whether this is truly a traction-induced pathology from the Achilles alone. And certainly our attempts to try to reduce traction oftentimes fail. And this might be elucidated from this interesting study published relatively recently by Lyman et al. In North Carolina, where they looked at the strain behavior of the distal portion of the Achilles. This was a laboratory study, and what they found was that the anterior portion of the Achilles doesn't receive the largest strain. It's the posterior portion. So this idea that the anterior spur at the insertion of the Achilles is due to traction has to be questioned. Stretching the foot and maximal dorsiflexion doesn't really seem to affect the part of the tendon at the anterior portion at the insertion. And placing a heel lift in the shoe would not necessarily unload the anterior portion of the Achilles. So we might think about using the brace system not so much to reduce tensile strain, but perhaps to reduce other stresses that occur at the Achilles tendon insertion from muscle activity or other loading forces. So we would think about using the carbon fiber brace to restrict dorsiflexion, but not necessarily longitudinal loading of the Achilles. We don't necessarily need to use heel lifts in this case because the research shows it doesn't affect the anterior Achilles. But it seems to affect muscular activity in the calf musculature, which may create the shearing forces we see and the resultant insertional spur. We're going to move on to the plantar fascia offloading system, which I think is the most interesting application for the AeroSpring brace system. And we want to look at what the research shows us in terms of strains that develop in the plantar fascia and how we might offload it. We often look at the truss system of the human foot and think of raising the arch of the foot to decrease tensile load in the medial central band of the plantar fascia. But we've learned that the medial arch is probably the least responsible for loading the plantar fascia. And as I'm about to show you, studies show that the Achilles tendon, and more importantly, the windlass mechanism with extension of the first MTP, are more significant in placing load on the plantar fascia. The windlass, for sure, is the most significant mechanism loading the plantar fascia. This study by Carlson, published in 2000, showed that the tensile force of the Achilles produces 314 newtons of force in the plantar fascia, while 45 degrees dorsiflexion of the toes creates 511 newtons in the plantar fascia. Overall, the plantar fascia is influenced 84% by dorsiflexion of the digits and only 15% by Achilles tendon force. Another study by Chang et al. Showed that dorsiflexion of the digits contributes 66% of the strain to the plantar fascia, while the Achilles tendon accounts for only 33%. Therefore, we really need to start looking at limiting or reducing loading of the first MTP and the lesser digits, which account for the primary strain in the plantar fascia. We've already learned that patients who suffer plantar heel pain generally demonstrate greater dorsiflexion of the first MTP, as demonstrated by Ryan Chang's study, as well as another finite element study published in the Journal of Biomechanics. That's why more and more clinicians are using rocker bottom footwear, particularly athletic footwear, to restrict dorsiflexion of the digits, anecdotally getting very positive results in symptomatic treatment and resolution of symptoms of chronic plantar heel pain, specifically by reducing the windlass effect. Another study published in Clinical Biomechanics showing that the rocker sole shoe, especially with a custom-made foot orthoses, has immediate therapeutic effects in offloading the plantar fascia and giving subjective improvement. So really, we could move beyond rocker sole shoes and insert the carbon fiber spring plate inside of the shoe. And studies have already been carried out using spring plates inside shoes, specifically for the first metatarsophalangeal joint. The study published by your colleagues in Australia, Shannon Montanou, showed carbon fiber spring plates significantly reduce dorsiflexion across the first metatarsophalangeal joint, and so doing can conceivably offload the plantar fascia. Another study done by Ben O'Nig and colleagues in Calgary with the Nike Free shoe with and without a spring plate, significant decreased loading of the first MTP, and more interestingly, decreased loading of the medial longitudinal arch. So the spring plate by itself has two positive factors on the loading mechanisms of the plantar fascia. Not to downplay the Achilles tendon, it still has an influence on the plantar fascia without question. And that is why anecdotally patients who do stretching exercises do improve with chronic plantar heel pain. So the ideal system to offload the plantar fascia would address tensile strain in the Achilles, but more importantly, reduce extension of the metatarsophalangeal joints, and through the carbon foot plate and the custom foot orthosis, stabilize the medial longitudinal arch. So that's what the AeroSpring brace system is best designed to do. Combine the foot orthoses, the carbon fiber AFO, restricting anterior migration of the tibia during the second rocker, decreases loading on the Achilles, and decreases muscular activity of the calf during the third rocker or push-off. Heel lifts alone are commonly used by clinicians to offload the plantar fascia, but let's look at how effective they are by themselves. We have seen studies, interesting studies, of the use of higher heeled footwear and the Achilles and offloading the plantar fascia. But what we found is that when patients walk in higher heel shoes, they actually have increased calf muscle activity. And this may actually increase strain in the Achilles. This has been shown in 2 high-quality studies published in the medical literature. Another study by Johansson showed increased EMG activity of the lower leg muscles when patients wore higher heel footwear. And they warned that clinicians treating Achilles tendinopathy with heel lifts or higher heel shoes should consider the compensatory activity of the gastrocnemius. Keep in mind, when we put a spring-like AFO brace on, a carbon fiber brace in these studies showed that it actually reduced muscle activity, and it can give an artificial push-off during the third rocker. So this is a positive change, completely the opposite of what happens when a patient wears a higher heel shoe. Now, we do know that when patients are placed in high heel shoes, there is reduced tension in the plantar fascia during quiet standing, not necessarily during gait, but it depends on the height of the shoe. In this study, a 75% decrease occurred in quiet standing in a 2-inch heel, but then the straining significantly increased in a 3-inch heel. So when we use high heel shoes to offload the plantar fascia, we may decrease strain in the Achilles. We definitely reduce pressure under the heel, but we might actually be increasing loading on the plantar fascia for other reasons. So some patients in higher heel shoes have relief of heel pain simply because there's less plantar pressure under the injured structure. However, there's more pressure transmitted to the forefoot. And when patients wear higher heel shoes, this study showed there is some relief obtained if the heel elevation is kept in the area of 3 to 4 centimeters. So that's the effect of higher heel shoes, but what about putting a heel lift inside of a standard shoe? We see the opposite effect. We actually see increased pressure under the calcaneus, increased pressure under the forefoot, and most importantly, a decrease of support under the midfoot area or the arch. This study showed that a simple heel lift, 20 millimeters under the heel only, increased plantar pressure under the heel by 50%. That's not very good if you have an acutely painful, swollen medial plantar calcaneal tubercle. The design of the lift is also important. A simple lift placed only under the calcaneus actually increases pressure under the heel, but reduces pressure under the midfoot, indicating decreased support of the shoe supporting the arch itself. So when we place a heel lift under the heel, we increase pressure in the ball, increase pressure in the heel, which according to the truss mechanism will load the arch and increase tensile strain in the plantar fascia. This simple heel lift leaving the midfoot unsupported increases pressure under the heel, increases pressure under the forefoot, and theoretically places greater load and elongation strain under the plantar fascia. If we use a heel lift with a foot orthosis, we now spread the pressure out under the midfoot, the heel, and the forefoot, and we have a better situation for decreasing strain of the plantar fascia. So we're basically wanting to distribute pressure more evenly from the heel to the ball under the arch with the foot orthosis. So by lifting the heel, we can contour to the arch in the midfoot, decrease load on the plantar on the Achilles, and not increase strain on the plantar fascia. Now, this is an interesting study done on heel lifts for plantar fascia strain by Kogler, which many of you might be aware of his famous 3 studies. And Kogler found when he placed a simple heel lift under the cadaver model, it didn't decrease strain in the plantar fascia at all. But if he placed a contoured platform that simulated the shank contour of a shoe, he had significant offloading of strain of the plantar fascia. He felt that it was important for the heel lift to contour to the midfoot, particularly under the cuboid, thereby shielding the medial aspect of the plantar fascia. I want to go back to that X-ray study I showed earlier with heel lifts. And this is interesting. Look at this picture in figure D. This patient has heel lifts under the heel that come out to about the cuboid, and the forefoot is allowed to plantar flex off of the heel lift. That plantar flexion of the forefoot may in fact have been what happened in Kogler's study, which offloaded the plantar fascia. If we lift the heel, reduce strain in the Achilles, but allow the forefoot to plantar flex off the heel lift, there's an automatic shortening of the medial truss structure of the foot. So the combination of a heel lift, a contoured foot orthoses, and making sure the foot orthoses is trimmed shorter to the heads of the first metatarsal to assure plantar flexion of the forefoot, we're going to accomplish everything that we want to do to offload the plantar fascia and decrease pressure under the calcaneus. But this concept of using a heel lift, supporting the tarsal bones proximally, allowing the forefoot to plantar flex slightly, is an interesting strategy, I think, to offloading the plantar fascia. If we can allow a little bit of plantar flexion of the forefoot on the rear foot, which can only be accomplished if we use a heel lift with a foot orthoses, I think we're approaching the offloading in a comprehensive manner. So to summarize, footwear with an elevated heel height decreases strain in the Achilles tendon, but it may increase calf muscle activity. Footwear with a higher heel height doesn't decrease strain in the plantar fascia, but only during quiet standing. Heel lifts inside of a shoe do not provide predictable decreased load in the Achilles or the plantar fascia. And in fact, a solitary heel lift inside of a shoe increases heel and forefoot pressure, leaving the midfoot unsuspended and compromising support of the longitudinal arch. So the strategy with a AeroSpring plantar fascia offloading system is using a carbon fiber AFO with a custom foot orthoses and heel lift. We're trying to restrict ankle motion, restrict calf muscle activity with loading of the Achilles, and don't forget the all-important effect of reducing extension of the metatarsophalangeal joints with the carbon fiber foot plate. That is a comprehensive system addressing, in my mind, all of the known mechanisms that cause load of the plantar fascia. Other conditions which we can apply this strategy would be the Lisfranc or midfoot sprain or degenerative arthritis of the midfoot. Midfoot sprains are common in sport, often misdiagnosed unless it's an obvious Lisfranc sprain that can be detected radiologically, but all too often athletes suffer a midfoot sprain without radiologic change, but are significantly debilitated across their midfoot joints and are told to go on crutches for 8 to 12 weeks to hopefully allow healing. We believe, based on research of carbon fiber AFOs, that it has the potential to significantly reduce bending moments across the midfoot joints. It's these bending moments across the midfoot joints that are extremely contributory to chronic disability of middle-aged patients, particularly women who have chronic midfoot arthritis for which simple foot orthotic intervention does not seem to be extremely effective. The transfer of load from the Achilles through the midfoot joints is the essential differentiating feature of the human foot for upright, efficient ambulation. And as we transfer load from the Achilles through the midfoot, there is significant strain that develops and compressive force through the midfoot joints to enable us to propel forward. This primarily occurs during the mid-stance period of gait as the tibia migrates forward over the midfoot and develops tensile strain in the Achilles. This is the second rocker as the tibia migrates over the talus. The tibia is restrained from anterior migration by activity of the soleus, and in so doing, considerable elastic energy is stored in the Achilles for push-off. Halfway into terminal stance, a tremendous amount of tension is developed through concentric contraction of the calf musculature, and as the knee moves into full extension, there's maximal load during the midfoot joints as the heel rises off the ground. We believe that the carbon fiber AFO can minimize the compressive forces across the midfoot during terminal stance, because during heel rise, the tibia is restricted from anterior migration. The carbon fiber foot plate provides a stabilizing force against ground reaction forces, and the recoil of the energy storage of the carbon fiber brace enables push-off without a delivery of force through the midfoot itself. Decreased calf muscle and Achilles loaded, and then as I showed you with the research from Ben O'Nigg's group, the carbon fiber foot plate significantly decreases loading across the medial longitudinal arch. So the spring plate alone already has shown a significant offloading and a change of angulation of the medial arch in a favorable way, which we believe can translate into less compressive force across the midfoot joints in patients with degenerative arthritis. Finally, we can use this bracing system as a strategy for treating neurologically impaired patients with drop foot. Already, many clinicians in Australia have appreciated the power of the Richie Dynamic Assist brace, which is a fully articulated spring-loaded brace to treat patients with drop foot. However, this brace has specific limitations. It must be used in patients with a stable knee, patients who have available dorsiflexion of their ankle joint without spasticity or contracture. Patients who have available range of motion of the ankle and good push-off power achieve remarkable control of drop foot during the swing phase of gait, along with good range of motion during mid-stance to enable push-off if their calf muscles are strong and active. What we're finding is this dynamic assist brace has had a remarkable effect on younger active athletes who have suffered traumatic knee injury with common peroneal nerve laceration or traction injury. This is a photograph, a famous picture taken of an athlete from Notre Dame University in the United States named Jalon Smith, who was the #1 rated defensive player in the country his senior year at Notre Dame, only to suffer a catastrophic dislocation of his knee in the final game of the season. Besides tearing the anterior cruciate ligament, posterior cruciate ligament, and medial collateral ligament, he severely traumatized the common peroneal nerve and had a drop foot. But he was able to return to play because he wore the Richie Dynamic Assist brace for approximately 18 months during recovery, but he still played football. With this brace intact, he had full plantar flexion push-off because his calf muscle was still strong and active. He wore the brace as a starting linebacker for the Dallas Cowboys in 12 NFL games in his rookie year, and he made the all-rookie NFL team. To his credit, with a lot of rehab, the common peroneal nerve recovered, and he was able to move out of the dynamic assist brace and signed a $30 million contract with the Dallas Cowboys to extend his career another 5 years. The dynamic assist brace, though, doesn't work for all drop foot conditions. In some cases, we need to use a more solid AFO to control tibia position. We want to control tibial position if the posterior musculature is weak or if there's contracture or spasticity of the calf musculature. In a case like this with severe genu recurvatum, a solid AFO can push the tibia forward and maintain a neutral position at the ankle. So a solid AFO has benefits over the dynamic assist AFO when we have instability of the knee or weakness of the calf musculature. As I showed you earlier, studies show that the energy storage of a carbon fiber AFO can enable push-off even when the calf muscles are weak. Compared to traditional plastic AFOs, carbon fibers give much better push-off and energy return. So comparing the dynamic assist Richie brace to our new AeroSpring system, we can use both anterior and posterior muscle weakness with the AeroSpring system, whereas a dynamic assist, if there's posterior weakness, we can't use it. If we have an unstable knee, we prefer the AeroSpring system. If we have spasticity and ankle contracture, we prefer the AeroSpring. Keep in mind the AeroSpring is a prefabricated brace. No casting for the brace, but we do cast for the foot orthotic component. The AeroSpring system might be perceived as a more bulky brace compared to the dynamic assist. For sure, the dynamic assist has a better shoe fit. The AeroSpring does not allow plantar flexion. That can be a good thing or a bad thing. And keep in mind that we have to prescribe a foot orthosis with the AeroSpring. So just to summarize, we now have a system to address Achilles, plantar fascia, drop foot conditions, midfoot sprain, and midfoot arthritis. These are all challenging conditions that, that podiatric clinicians face regularly. How do I order an AeroSpring? Well, the brace itself is ordered according to shoe size, right or left. It's almost always ordered unilateral because most of these conditions present unilaterally. Foot orthoses are required, and we recommend impression casting or scanning. Both can be accepted by Queensland Orthotic for the orthoses. The heel wedges are ordered according to practitioner preference. We do give you a recommended protocol, but you're welcome to order the heel lifts according to your own patient requirements. So Queensland Orthotic Lab is our exclusive distributor in Australia and in Asia for the Richie AeroSpring system. Shoe size is critical. Scanning can be taken of both feet, and the scans can be sent via email to QOL. We still accept plaster or fiberglass casts of both feet, just as you do for foot orthoses. Fitting the brace in the shoe is quite easy because this carbon fiber brace has a special distal and proximal aspect that are trimmed with scissors. It's a high density fabric material that extends just beyond the carbon fiber foot plate to be able to modify the fit inside the shoe within one full shoe size, so no grinding is necessary. This is the prescription form which you can obtain from Queensland Orthotic Lab, and you can also get pricing and other policy requirements from Queensland Orthotic Lab, located in Queensland, Australia, exclusive distributor of the Richie AeroSpring brace system. And happy to take any questions you might have.
Doug, there's a couple of questions that have come through in regards to using this AeroSpring brace in the Charcot foot. Can you comment on that, whether it be for people who are in the early stage of developing a Charcot foot or even that sort of chronic Charcot foot?
Yeah, that's an interesting proposal. Other people have brought that up. I always say a Charcot foot is a combination of a drop foot and adult acquired flat foot. Patients with Charcot arthropathy obviously have equinus. They have contracted heel cord for various reasons most of us understand. But what people often overlook is they have a drop foot. They have anterior muscle weakness. They tend to contact the ground with a forefoot strike. That tends to load the forefoot and increase risk of ulceration. I have not done any clinical testing of the carbon fiber brace on patients with Charcot, but I would say, at least from a mechanical standpoint, all of it makes sense, particularly using a more accommodative orthotic design for the Charcot. We have to take into account there's still going to be some balance issues with these patients who are already impaired with their neuropathy. However, a lot of patients with Charcot are treated with other forms of offloading, including total contact casting, which to me is more difficult than adapting to than a carbon fiber brace. So I would say the evidence is there that all of it could be beneficial. And I think for the right patient and the right monitoring, I think it's a viable consideration. Yeah.
Great. Thanks, Doug. There's another question that's come through asking, can we scan for the brace? That's correct. All you need to do is take a scan of the foot itself, like you would a foot orthotic scan. So it doesn't need an ankle high cast like the other forms of Richie braces. So I hope that answers that question.
I might just jump in one with, sorry.
Yeah, go for it, Josh.
Jump in with one that you were probably about to ask. This was the question I was interested in, Doug, is that if somebody has recently bought or has existing custom foot orthoses, do they then need a new pair to get into the brace, or what's the process for sort of retrofitting existing orthoses?
You know, that's a great question. And that came up early on when we released it here. We can place the current orthoses in the brace. They don't have to get a new pair.
Do they need to send those orthoses to the lab to have that done, or does the podiatrist do that in the office?
I don't think they need to send it to the lab. Now, the key though is I'm going to back up, because we Velcro the heel wedges to the under surface of the orthosis. I think that Kent could probably put a Velcro piece on the top surface of the heel wedge, and then provide the practitioner with a similar Velcro match on the other side, so they wouldn't have to give up the orthoses. So I think that's doable, but we do like to Velcro everything in there so there's not any slippage inside of the shoe.
Yep. Okay. Thank you. Another question in regards to footwear, Doug. You know, with the lift that's incorporated into the AeroSpring system, is there any particular type of footwear that would be recommended?
Yeah, so this gets a little tricky. I find that patients can do fine with 20 millimeters, 2 centimeter lift bilateral in an athletic shoe. When you go to 30, it's a little precarious. You definitely want to go with a really deep heel cup running shoe, and usually those are motion control shoes. And it's still a little precarious. When they're in a 30 millimeter lift, they're usually not in an active phase of their recovery. They're still very restricted with the amount of weight bearing. I, for one, rarely used 30 millimeters. And as I tried to show in this presentation, even with an acute rupture, 20 millimeters is adequate. And patients do fine with 20 millimeters. 30 millimeters is tough. In terms of the contralateral shoe, women do great because they can wear a wedge sandal of 30 millimeters and match it up. But that shoe that the brace is in, they're going to be coming close to coming out of the shoe, but it can be done. They just have to be careful.
So most forms of athletic footwear are appropriate? Absolutely. Another question.
And on that, Matthew's asked about how it would fit into a football boot. Given the NRL example that you showed before, Doug, with the with the rigid brace, I presume it can fit into a football boot or a soccer cleat. Okay.
Yeah, it can be trimmed. I would question. You have to understand all of these pathologies I showed you are debilitating injuries. They're conditions that patients are going to be taken out of sport for a while they recover. I guess there's some cases where an athlete might wear this inside of a competitive athletic shoe that are back in training or competition, but for the most part, these strategies are for patients who are in a recovery mode. They're not.
So that example that you provided before with the NRL player, that wasn't the aero brace, was it? That was a different type of AFO.
Which example?
The NRL player, the elite football player.
Smith.
Yeah, that was, those were on running athletes with a carbon fiber foot plate inside the shoe.
Yeah.
Which absolutely that can fit inside, and it is done commonly for turf toe and other injuries.
Doug, a good question here from Ruth. Can you clarify the protocol with acute Achilles that's suitable for conservative treatment? And do you use a cam boot whilst waiting for the AeroSpring brace to arrive?
Yeah, it's a good question. I think a patient who has just suffered an acute Achilles probably should be treated just like an athlete with an acute ankle sprain with rest, ice, compression, elevation, usually a compression bandage, and nothing wrong with putting them on crutches until the soft tissue part of the injury is healed, which gives you ample time to order the AeroSpring and get it back hopefully within a week. And then we allow immediate weight bearing in the AeroSpring with 20 millimeter heel lift bilateral. Absolutely. But I think the first week they should be treated because they have an acute injury. There's a lot of other soft tissue problems to be concerned about.
Thanks, Doug. A good question here from Colin. Would this be suitable for a post-Lisfranc's fusion that's still troublesome a number of years later?
Oh, absolutely. I treated a couple Lisfranc sprains, and I managed a couple surgical patients with this post-op. And, the typical strategy with Lisfranc is to put them non-weight bearing for a long period of time. And the first problem is we know these patients aren't non-weight bearing. They don't follow your instructions. They walk on it. And a walking boot by itself is not adequate to support the midfoot joints. I think there's probably a lot of motion there. But I think putting them in a carbon fiber brace with a well-molded foot orthosis is going to negate most of those deforming forces that go through the midfoot. And these patients walk relatively normal, that I think the compliance is far greater, I know it is, than in a walking boot, that I think we can even come in with a neglected, delayed healing and at least calm down the symptoms and maybe avoid a reoperation. Absolutely.
Great, thank you. Nigel has asked, is it more common to use EVA orthoses over polypropylene as part of the bracing system?
That's a great question. I think, with that plantar heel pain and where you're trying to get a little bit of plantar flexion of the forefoot, and I think putting them in a more compliant orthosis, EVA, that's a little more flexible in the sagittal plane, allow it to conform to the foot and to the heel wedge, in that case is better. You got to keep in mind, this is a really pretty rigid brace system. And I don't want to say this across the board, but putting a rigid orthotic on top of a carbon fiber foot plate might be a little bit of overkill. And I never was a big fan of EVA orthoses or so-called accommodative softer orthoses, but I was amazed how well my patients did in the AeroSpring system when I moved them to a softer device, a little bit more compliant, and particularly for plantar heel pain.
Thanks, Doug. I might just jump in again quickly, Kent, if that's okay.
Yeah, sure.
And the one I'll just finish on here, Doug, is just a clarification. So someone's asked, when we have a patient with the AeroSpring on the left foot and a 20 mil lift, what do we do on the right foot to compensate for that limb length discrepancy?
Yeah, so you're going to put them in bilateral custom foot orthoses because the AeroSpring requires a foot orthosis to be effective. And you're going to put the same amount of heel lift under the contralateral foot as you have on the AeroSpring. Absolutely.
Well, I might sign myself off and say massive, great big thank you, Doug, for the fantastic presentation. It's always enjoyable hearing from you. And thanks, Kent, so much for co-hosting it with me.
Thanks, Josh. Thanks for organising everything. And again, yeah, thank you to Doug for a fantastic presentation.
My pleasure.